Welcome all. Really pleased to have this new format where we're down to 90 minutes. We'll focus on specific targets or specific topics so that we're not sort of spreading peanut butter like so many really big issues, and maybe we can make some really good progress this year. So thank you. Our agenda is really focused. And we're going to, let me just kind of see, we're going to primarily focus on looking at our calendar and some program updates. And then we're going to move right in with Ralph walking us through his presentation of the Prescription Drug Affordability Board recommendations. And we're really going to hone in on that, and we'll have some framing of that piece right before to kind of think what our obligations and our role with that affordability board is. Any comments or questions on the previous meeting summary? I think there was one in the back. And do we need to call members, Sarah, or are we all set to go forward?
We are capturing everyone as they log in, so we don't need to call the roll unless you would like to, and we do not need to formally vote or anything on the meeting summary, but the November meeting summary is in the materials.
Excellent. All right. Do you want to walk us through the calendar?
Sure. Johnny, let's go ahead a couple slides. One more. Yep. Okay. So in the meeting packet today, we have provided an updated and expanded work plan or sort of overview of 2024 for the year. It includes all of the Oregon Health Policy Board meetings, which are shown on this calendar slide here in yellow. It includes all of our committee meetings shown here in blue. We have tentatively scheduled the date for our public hearing. The policy board has graciously agreed to host that public hearing. And we also have the date for our in-person meeting. Also in this calendar document, you can see the topics for the year that we have scheduled for each meeting. You can also see when things will intersect with the board, as well as some key activities for the cost growth target program. So when we anticipate releasing certain reports throughout the year, when various other activities, including committee member recruitment, approval of new members, data submission due dates, those kinds of things, rulemaking, all of that, how they all weave together so you can just see the whole picture for the year. Also, as part of this calendar, we had talked in November about doing starting an educational webinar series. We know that there are a lot of topics and a lot of things that we probably won't have a lot of time for in our new 90-minute meetings. And so we wanted to carve out some separate space for that. We have not yet started scheduling those. You'll see some placeholder dates for January 30th in the rest of this slide deck. Ignore that. That's not going to happen. We'll start scheduling those educational webinars for February. You can see the potential topics for those educational webinars throughout the year, also woven into that 2024 document. And we will be letting committee members know. We'll also let our technical advisory group and our broader Gov Delivery distribution list know when those webinars are scheduled and what the topics are. They will be open to the public. They'll be recorded and posted, so you don't have to listen live, but you'll be able to get the information later. So that's the calendar. There's a lot of information that's been packaged up. I don't think there's anything that's really changed since we talked about this in November and set this intention, but wanted to make sure everybody had that and had a clear picture of the year ahead. Any questions or comments about that? Okay, let's go to the next slide. Next slide. Okay, so Unfortunately, I have some sad news to share. In November, we welcomed 3 new committee members, and unfortunately, one of them has had to step down. So Kate Dennison has taken a new role and is no longer part of the committee. And so we have opened up a new recruitment again for a consumer advocate or a consumer representative. So this recruitment is open. We're looking for applications between now and February 16th. We'll be doing a lot of staff work to help get that recruitment out there and talk to folks who might be interested, but I encourage committee members, interested folks to help spread the word, help boost that, and applications are due in February. So trying to keep our committee fully seated.
Yeah, actually take a moment to think about who you might know that would benefit this work. This work is building over the course of time and is becoming very impactful to our industry. And we need good colleagues at the table to help us do the best work we can to guide OHA through the process. That was my editorial, Sarah.
That was great. Thanks, Peter. Charlie.
On that point, well, Kate was at DOJ. Was she representing DOJ, or was she just kind of so I guess the question is, are we going to try to get someone else from DOJ to replace her, or is that just a broader?
No, it was a consumer representative seat, and it was really interesting to see Kate in her role, not specifically DOJ. We didn't have anyone from DOJ previously, so I think we're who started with us in 2022. The policy board appointed you for an initial 2-year term. That initial 2-year term will be up in May of this year. And so this is a friendly reminder, friendly heads up that we will be reaching out to you all probably starting in February, maybe March, to check in and see if you are interested in extending your term and continuing with the committee, or if you are interested in stepping down. So we don't want the entire committee to turn over in May. So we do want some folks to stick around and extend for continuity and have a rolling membership. So we're going to be checking in with folks individually. We know some people are in different places, work focuses, work priorities, availability might have changed. So we'll check in with everybody about that. And then once we have a sense of sort of how many seats will turn over in May, we'll open up a recruitment that'll be more broad than this current one. So much more to come on all of that. We'll talk to all of you individually about your interest and ability to want to continue on for another term with the committee, but that's coming soon. Questions or comments about that? Okay, next slide. Okay, also wanted to share with everyone that we are about to start our rulemaking. So this is the process that we go through to develop and codify the operational and the administrative rules for how parts of the program work. This rulemaking will be focused on accountability. So how do we determine good, reasonable cost growth from unreasonable cost growth? What do performance improvement plans look like, and how do they work? And financial penalties. So we talked about these components a lot over the last 1.5 years with you, and now we're moving into this rulemaking phase. We opened a recruitment and convened a rules advisory committee per state process. We had really good response. We have more than 40 members of the RAC, and the first meeting of that RAC will be next week. So this was a virtual meeting. It's also open to the public, so any committee members are interested to listen in. We'll keep you updated on what's happening at the RAC, but that first RAC meeting is coming up next week. We're hoping to send out materials and post some of the drafts related to rulemaking probably tomorrow. So a little bit more to come on all of that. Questions about the rulemaking or the upcoming RAC? Oh, and in case I didn't say it, these meetings will also be recorded and posted online, so anyone can also listen in or catch up on the RAC if needed.
I do have a quick question, Sarah, on the RAC. Is that where they actually set the criteria, or is that like the advisory committee, they put a recommendation out and it goes to another group to take that information? I just understanding the process a little bit more.
Yeah, absolutely. And I think we shared a slide about the process in November. I can send that back out to folks if it would be helpful about the process. So the Rules Advisory Committee is advisory, but they're advising OHA. So they will look at the draft rules, they will look at draft sub-regulatory guidance materials and things like the PIP template, and they will provide feedback, input, comments, and then OHA makes the final decision on that. So there's not another committee or body that's coming after the RAC.
Perfect, thank you. And I have the information from November, but I appreciate the reminder.
Great. Okay, and next slide. I think this is my last update. So we wanted to share with you that our 2023 Oregon Relative Hospital Price Report is coming soon. We're hoping to have it out before this committee meeting. Didn't quite make that, but coming soon. This is an annual report. We published it last year, and this is the update, and it compares commercial and Medicare prices for hospital inpatient and outpatient services. So this report was of a lot of interest to committee members last year. We are hoping to do an educational webinar on it to share the data, walk through the report in more detail, have chance for Q&A. We were going to do that January 30th. That's not going to happen. I think we're now thinking mid-February. So we'll reach out about rescheduling that, and that report will hopefully be published really shortly. Okay, I think that's all for program updates. Thank you.
You ready for some framing, Sarah?
Yeah, I think we've got some framing slides for you, Peter. It is all you.
Okay. I want to talk a little bit about, first of all, Ralph's going to come and present the recommendations as I discussed. And this is just a really, really important component of cost growth. And as you know, pharmacy costs are really one of the major drivers. The cost trend for pharmacy over the past decade has been well in excess of the cost trend for medical, whether that's both at the hospital system or at the provider system. And one of the risks that we have as a committee is to focus on those folks that are around the table, that are driving this work, that are local providers, whether health systems or small providers, or by external. And we absolutely can't get to our goal without impacting those external folks that aren't at the table. Obviously, prescription drugs are a really significant driver. In my tenure at Pacific Source, we've seen the cost of prescription drugs go from a little over 10% for our commercial members to well over 20% of the total cost for our commercial members. The only way it gets there is for the development of new drugs, the increase in pricing costs, and the increase in utilization. But nonetheless, the trends on those costs have gone up very substantially relative to the trends in the work that a lot of you around the table control. So I just think it's really important that we figure out how we coordinate with the Affordability Board and help understand what their recommendations are and how we can help to apply them to meet some of the goals that we have. You know, if you look out, and we've talked about these in the past, but if you look out to some of the great technological breakthroughs, whether that's the potential that GLP-1 drugs have, or it's the cell and gene therapy drugs that are very, very expensive and really impactful for individual members. We've got to better understand how we can make those technologies available to our members, but also not blow up the pricing trends that we've set as goals. And I'm not sure anybody really knows how to address that challenge, but it's one of the challenges that we have. The committee spent some time late in 2022, early in 2023, talking about potential strategies to address pharmacy cost growth. Ralph will walk us through their current recommendations. Many of you have also seen some of the new approaches, which are sort of trying to create band-aids on the fact that negotiating for pricing of drugs within our state or within the country is very difficult. So Florida's reached out. There's been some legislation that approves them taking a look at buying from Canada. I think that's a stopgap measure, but I'll look forward, Ralph, to your thoughts on where we're going, and then maybe what some of these alternative strategies might be over the course of the next couple sessions. I know that we'll have another chance to have a conversation about pharmaceuticals come February. So Ralph, I'm going to pass it on to you.
Hey, thank you, Peter. And just to do a listen check, everybody hear my audio okay? Great, thank you. Good morning, everyone. I'm Ralph Magrish. I am the Executive Director of the Oregon Prescription Drug Affordability Board, also known as the PDAB. Thanks for the invite to talk with you this morning, both about the Drug Affordability Board and the Drug Price Transparency Program, which is housed at DCBS. And just to speak to that for a quick moment, there's a lot of overlap, I think, as the introduction reference between the work that our Affordability Board is doing and the Transparency Program. And for that matter, both entities or bodies making programs making discrete recommendations. So going to speak to both of those today. If it works for you, I'd like to cover the first half of the deck, which is the Drug Affordability Board, and then pause and we can have questions and discussion then, and then move on to the transparency program. But we'll also note and kind of co-opt something that Peter said during some of his opening remarks, and that was relative to the cost growth target, and said something to the effect of impact building over the course of time. I'd note that's what we're trying to do as well in our kind of year and a half of maturity too. So long runway, and we're moving down it as fast as we possibly can. Durande, next slide, if you would, please. Thank you. Thank you. So in brief, just a couple slides of introduction. The board itself was created, Senate Bill 844 in 2021. We had our first meeting in June of 2021 with the charge of protecting Oregonians, the state, local governments, commercial health plans, providers, pharmacies, and others within the healthcare system from the high cost of prescription drugs. This past year, our board was expanded by the legislature to include 8 full voting members, all appointed by the governor and confirmed by the Senate, with the prerequisite that they have a background in clinical medicine or healthcare economics. And next slide, please. Thank you. So just a little bit of the highlights, and I'll get into the weeds in each of these, but from this past calendar year, we did a generic drug market report that went to the legislature in June, and we will be resubmitting another one in June, which is not far away, and I'll speak in some detail to that. We launched our affordability review process with our legislative charge to identify 9 drugs and at least 1 insulin product that do create affordability challenges for Oregonians, and then finally making policy recommendations to the legislature, and we will jump into each of these. And next slide, please, Durande. Thank you. So to speak about our generic drug report, and I think the link is available at the bottom of this slide, but in short, prepared this report to look at drug shortages, price fixing, pay for delay, spread pricing, market disruptions, and potential for biosimilars. So there's a lot of conversations to unpack and flag there for future evaluation and consideration. More recently, there's been a lot of attention to drug shortages. The system is actually set up so that manufacturers declare shortages themselves, not the FDA. We see a lot of shortages develop as manufacturers make the conscious decision to stop making a drug product when it's not profitable enough. So while that's capitalism and a free market, it does bring up a lot of difficult questions, like should the government play a role in contracting with generic manufacturers to produce sufficient low-cost drugs to meet these kinds of issues and shortages? Don't have answers, but these are the difficult policy questions. To that point, what kinds of perverse incentives would that create unto itself for manufacturers to exit a marketplace for drugs that they did not deem profitable enough to continue manufacturing? Issues like why formularies are actually often stacked with brand name drugs when there are certainly less costly generic versions available, but for rebates being paid by manufacturers through PBMs for product placement on formularies, that then creates that cycle of structural disincentives for generic manufacturers to produce certain drugs. So it's quite a tangled web. As I mentioned, we're working on our next report for June for the legislature. Lots of issues around biosimilars, and we'll speak to that in one of our policy recommendations as well. So next slide, please. Thank you. So our main charge, as noted, is to conduct these affordability reviews to identify drugs that create financial hardships for Oregonians through high out-of-pocket cost or the healthcare system. So I think, as most of you know who have been plugged in and worked in government or been a part of these processes for some time, as you know, a transparent rulemaking process unto itself can take about 6 months. So we did that during the first half of 2023 based on substantial stakeholder input. We promulgated 2 new rules, and the first one being both consistent with statutory provisions, how to select drugs for affordability reviews, and then secondly, the framework for which we will conduct these reviews. And I'll speak to that in a little bit more detail as well. And I'll also note that our drug price transparency, the legislature in its wisdom kind of created a synergy between the 2 programs. And that is that the transparency program, which you'll hear about, actually produces kind of feeder list, if you will, that collects specific pieces of information from state licensed insurers and drug manufacturers themselves, as, like I said, the feeder, if you will, for the board to discuss and deliberate amongst that universe of drugs what the board ultimately might vote and deem to be unaffordable for Oregonians. So for prescription drugs, and I think we have this in the slide here, in conversation in board meetings, the board started with a universe of about 300 drugs and has narrowed that list down to 12, for which it will begin conducting its affordability reviews in February. And similarly on insulin products, we started with approximately 66 insulin products and are now down to 3. The affordability reviews for insulin products will actually begin this Friday at our affordability board meeting, I think 1 to 3:30 or 4 o'clock in the afternoon. Encourage and welcome folks to sign up and participate, or sign up for public comment if they're so interested. To that point, the affordability reviews for those insulin products are posted to our website. So a little bit of the nickel tour on those. The data included in them includes pieces like clinical, cost, and access profiles, as well as the cost of therapeutic alternatives, and of course, stakeholder feedback. So that is the process for which we are carrying forward. And it is our plan and intent to meet our deadline to submit, as noted in that 3rd bullet, by the end of June. And Geronde, next slide, please. Thank you. So as also mentioned in our opening, one of our other charges is to make policy recommendations to the legislature. So we actually took a different approach this year. I think it was an interesting one that we learned some lessons and got some good consumer engagement. But our board chair asked that we take 2 steps back and we engage community in submitting potential policy recommendation concepts, if you will, to the board. So we invited the general public and interested parties in September and October to submit possible policy recommendations for the board. to consider, and those which you have in front of you were the ones that were accepted. And of course, not only do we submit those recommendations to the legislature itself, but we submit as required in statute to you as the Cost Growth Advisory Committee as well. So just to hit these at 70,000 feet, first one is to lower the insulin copay, and I will speak to all of these. Second is change in Oregon's law regarding biologic products and substitutions, and then some enhanced reporting for pharmacy benefit managers. So we'll get into some detail on each of these. Next slide, please. Thank you. So as mentioned, and Sarah, thanks for dropping that link in. As mentioned, we did this and get community engagement process to solicit potential ideas from community. The one that scored the highest, if you will, through our process was to support one submitted by the Diabetes Association to reduce the insulin copay to $35 and decouple it from the CPI. And to that point, just a little bit of context, and I suspect many of folks know this, but who is that universe applicable to, even in current statute, that has the insulin copay of $35 that is tied to the CPI itself? It includes fully insured individuals, people in small groups, large group plans, which in totality include approximately 1 million Oregonians. It does not include folks that are in self-insured plans that are not regulated by DCBS, nor does it include Medicare or Medicaid beneficiaries. As the context for that, the out-of-pocket costs for insulin were capped to annual price increases tied to the CPI, higher than expected inflation, as we all know, in 2022 to 23 led to faster growth in the CPI and faster growth in Oregon's insulin cap, which turns out to be $85 in plan year 2024. Lots of other moving parts in the insulin supply chain that likely don't need to get too far into the weeds here, but we'll share some very exciting news as this was our prime charge. I was invited to speak at the Interim Senate Healthcare Committee a couple weeks ago during legislative days and present on this, and very pleased that Senator Patterson, chair of that committee, has shared with us that while there was no bill vehicle specifically available, the committee did deem this to be an important enough issue that it will be including it in its committee bill. So very excited about that, very encouraged, and we believe that we will be making a difference in the lives of Oregonians. So we're excited about that, and we will see where that goes. Next slide, please. Our second recommendation was to change Oregon statute for substitution requirements for biologic products and biosimilars. And this is likely a much longer and larger issue and conversation than time will permit to be addressed in a 5-week session. But I think I intimated some of this when I spoke about the generic report that we will be building out, but lots of issues in branded manufacturers incentivizing their products to be placed on formularies, which makes it harder for biosimilars to get traction in the marketplace. These also can be hindered by the use of branded manufacturers using patient assistance programs and consumers' understanding of ultimately what biosimilar products are versus the reference product. So lots to unpack there. I think we'll be diving into that a little bit more this year and potentially engaging in some other conversation with policymakers on that. And next slide, please. Thank you. So to expand on the pharmacy benefit manager reporting requirements for more transparency, there has been some movement in Congress in moving a couple different bills through both chambers. Not sure where that will land, but we'll tell you and set stage for some of this recommendation. And you may recall, for those of you that were with us last year when we presented, during the board's inaugural set of recommendations to the legislature, we included in those recommendations a requirement for pharmacy benefit managers to start reporting some very baseline information to DCBS, to our transparency program. We were very pleased and very proud that that did make it into Senate Bill 192, which did become law. And that is, I'll give you just a little explanation as to what our starting point with that is, and then potentially where some of this might go in a future recommendation. So to that point, beginning this spring, in fact, we are just wrapping up our rulemaking process on this right now. Pharmacy benefit managers, or PBMs, will be reporting to DCBS each calendar year on the following data points: the aggregated dollar amounts of rebates, fees, price protection payments, and any other payments that the PBMs receive from manufacturers relating to their carriers that issue plans in the state that were A, passed on to carriers issuing those plans, or enrollees at the point of sale when the prescription drug was acquired, or finally retained as revenue by the PBM itself. So again, in the context of change being incremental, this was a logical, intuitive place for the board to start with a recommendation, and pleased that the legislature accepted that, to the point of the board's recommendation for a little more insight into that. I think, as noted in the slide, some of that stage was set by the Secretary of State's office in their audit of OHA and the CCO oversight and processes, potentially of putting some additional reporting requirements on those pharmacy benefit managers that serve OHP members enrolled in coordinated care organizations. And next slide, please. All right, so really excited to share this piece with you. I'm glad that I'm able to speak with you as a committee with such diverse membership across the continuum of entities and people that we ultimately want to engage with. So for a number of you that had tracked what the Affordability Board was moving through legislative concept in 2020 through 2021, and potentially what other states have in their authority, our PDAB does not have statutory authority to set upper payment limits for prescription drugs. It was a policy recommendation of the PDAB in its inaugural round last year to give us the authority to do that for government payers only. The legislature did not think that was the appropriate course of action at that time, but believed in the work that we are doing, and to that point supported in Senate Bill 192 for the PDAB to develop basically an implementation / operational / analytic / cost savings benefit analysis project / report due to the legislature in September. And specifically, it calls out for us to develop and identify a methodology and look at what resources will be needed and involved there. So to that point, I'm very pleased to announce that just in the last week and a half or so, through a competitive bidding procurement process, our program did award a contract to Myers and Stouffer. They are a national consulting firm that works strictly with government payers, largely in the prescription drug reimbursement and supply chain space. They also do support CMS in their National Average Drug Acquisition Cost, or the NADAC pricing benchmark, which many states use to set a reimbursement benchmark for pharmacies. So we'll be having a kickoff meeting with them in the next week, and then subsequently be working with them to engage stakeholders. And we'll speak to this for just a moment. So to that point, statute calls for the board and our contractors to engage the state. That does include the PEB OEB folks that we've begun working with, certainly the Medicaid folks and Care Assist, the HIV program at OHA, state licensed insurance carriers, hospitals, pharmacies, consumers, and whilst not statutorily called out, 340B covered entities. So we will be having our kickoff meeting with our new vendor next week and anticipate a series of probably 3, 4 or more kind of focus groups and data calls with these individual entity types. Have begun collecting names and contacts for insurance companies, hospital folks through contacts at OHA, and pharmacies through the state Pharmacy Association, and for FQHCs and other 340B covered entities have begun working closely with the Oregon Primary Care Association. So more to come on this in outreach, but lots to come in some of this conversation. Dronde, if I could ask you to advance to the next slide. Thank you. So vendor procurement, as noted, this ran us through October into November, and we're beginning our communications and outreach, and you'll see what our runway is for that. But we'll speak to this in a little bit of detail. A lot of this is about seeing what makes sense, and you have to start the conversation. We know that the prescription drug supply chain reimbursement mechanisms are mired in obfuscation and a lack of transparency in these very complex business transactions. So again, bringing folks to the table to see what makes sense, where is transparency needed to make that happen, and to that extent, how do we get there from here, if you will? So both an analytic and kind of a consensus building straw model exercises, and some real, quite honestly, probably some difficult conversations that need to be had. And if there is one thing we know in our work is that you know, there is no one size fits all silver bullet or panacea. These are really going to be kind of developed through a lot of difficult conversations. And that is to say that, you know, in that one size fits all approach, that conceivably for drugs that are highly rebatable, maybe a different strategy for setting or developing an upper payment limit than a drug that has a significantly lower rebated, you know, amount to it. So lots of difficult questions that we'll start unpacking. And again, excited that we've already begun working with the PEB-OEB folks and establishing these contacts with our community partners, and looking forward to working with our new vendor to engage folks. And I think that is the end of the PDAB presentation. Why don't I pause and see if committee members have questions before we move into the transparency piece.
You know, Ralph, I had a quick question. Is it some of this work impacts the cost growth target? You know, if I think about the insulin copays and caps, they're extraordinarily important for members that utilize those services, but they don't necessarily, am I correct that they don't necessarily get at the cost of the insulin to the whole system? And therefore, there's a protection for individual members, but it doesn't necessarily start resolving some of the trends we see as the overall system cost.
I think, yeah, Peter, I think that's an accurate high level statement. You know, as we're learning with all these things, the devil is in the detail, and that, you know, quite honestly, around insulin, I'm probably not telling y'all anything you don't know. Insulin was invented over 100 years ago, right? So to the extent that, you know, the pricing structures are what they are, that there's a lot of moving pieces, including something I did not include in this deck, but for the phenomenon of best price in Medicaid, which some folks may be familiar with, and that effective January 1st, there was, for lack of a better term, and lack of time to get too far into the weeds on this, rebates that manufacturers paid or reimbursed back to the federal government for Medicaid utilization had been capped based on the CPI and a couple other variables. At beginning January 1st, a la 22 days ago, that cap ended. So, you know, some may claim altruism, some may claim business decisions, but to that point, a number of insulin manufacturers have lowered the prices significantly on some of those products. To that point, some, not all. So certain kinds of delivery systems, be it flex pens or other kinds of mechanisms that, you know, ultimately help with adherence as much as anything else, right? You know, are really important. So it's quite complicated. To that point, there are a number of other kind of market disruptors that have come on the scene, including the Mark Cuban Discount Pharmacy, Civica RX, and other folks. So not sure, Peter, that I was able to really answer your question, you know, perfectly, but a little bit of commentary, and happy to have conversation if you'd had some follow-up.
Well, I think your answer is really helpful. It both points out sort of the copays and overall caps for members don't necessarily affect the overall costs that we're dealing with as we think about trend, but there are a lot of other initiatives that are driving some of those underlying trend costs that
Yes.
impact our committee. And I think it's important for us as a group to understand where we can really impact our ability to hit some targets. So thank you for that.
Absolutely. And just maybe even to opine on that for a moment, some of the conversation around this $35 insulin cap is that that is actually, some pharmacies are actually reimbursed more than that $35. So the fact that there's that kind of, and when I use the word bloat, please note that I am not referring to the pharmacy, the community retail pharmacy in that statement, but the construct that someone could walk into a pharmacy with a valid prescription and conceivably pay $35 in cash to get insulin, whereas they may, through their carrier, need to pay, until this springs into effect, up to $85, really is representative of a very distorted marketplace, and distorted being a kind word. So, and if any other questions or comments, happy to move into the transparency portion. All right, Dronde, if you would. Thank you. So the transparency program housed at DCBS operates under statutes in the insurance code and requires insurers to report information to the program as it does manufacturers. And I'll speak to some of the detail in that if you would. And next slide, Dronde. Thank you. So all directed by statute. On the manufacturer side, we receive reports from drug manufacturers that we consider new drug specialty reports. Specialty is honestly quite a bit of a misnomer in this construct. It is a CMS mechanism for which they identify drugs that are over a certain dollar threshold, which at the point in time of this was $670 for a 30-day supply. Submit reports of annual price increases when prices go up for $100 or more, and 10% net yearly increases, and then 60-day price increases. The insurance carriers in our state, as many of you are familiar with already, submit their top 25 list to the state on those most costly, most prescribed, and the effect drug cost on premiums. And then we will begin this pharmacy benefit manager reporting that I spoke of this calendar year as well. And we received quite a bit of input from consumers, and we again, thank certain folks. Actually, there are members of this committee that have helped us with that engagement. And I'd call out Charlie and Osberg specifically for their help with in engaging consumers. So we're grateful for that. Thank you. Yes, we do, and we'll share that with you, Felicia. And I believe we probably have the link in the slides forthcoming. So if we'll get there momentarily, or I think perhaps Sarah might be able to drop those in if you would. And next slide, please. All right, so as mentioned, we have our consumer-facing pieces where everyone, thank you, Sarah, so much. Consumers do tell their stories, and we're really pleased that during our drug price transparency hearing that we held in December, that we had more consumers engaged in signing up for testimony and speaking of the hardships and stories that they face in these. And to that point, can tell you that their voices were heard loud and clear because our moderators were all state legislators, and proud to also say it was the first time that we've had broad bipartisan representation of legislators as moderators for that hearing as well. And to that point, our transparency website, which encourage everyone to review, does contain non-trade secreted information from manufacturers and all this carrier information. And we'll get into the weeds in that in just a sec. Dronde, if you would go to the next slide, please. Thank you. So these are just a few key findings from the 2023 report. The highest price increase was for a new drug reported was $3.5 million. This was for Hemgenix, a hemophilia B treatment by CSL Behring. The largest price increase on the annual price increase for a generic drug was a generic vitamin A solution from Casper Pharmaceuticals, a 25% increase. They went up to $718. And then, of course, Humira, made by AbbVie, continued to be the most expensive drug reported by insurers, and a cost that exceeded $75 million in 2022. And next slide, please. So mentioned, this is all manufacturer reporting. We'll go over some of this data with you for new specialty and annual price increase report. So showing the total number of reports that we've received year over year for the last 5 years from manufacturers. On the left side, we have the new specialty drug report. So again, as noted, that's for drugs that are $670 or more for a 30-day supply. Excuse me, on the right side, you have annual price increase reports displayed for which drugs for which there was a $100 or more increase in a 30-day supply, or 10% year over year increase in their average price throughout the year. This is divided and presented as both brand and generic drugs for your reference. The blue bars are brand and the orange bars, of course, being generic. So I think the thing that's noteworthy here is that we've seen an increase in these reports for both categories year over year, and it's been steady throughout the life of the program as far as new drug reports. But at the same time, throughout the life of the program, we've seen a decline in the number of price increase reports. And purely speculative, but kind of think that this changes a strategy on the part of manufacturers to have higher list prices and then do fewer price increases throughout the life of the drug, and a trend that we continue to see. So if you would, next slide, please. And I think this is one that folks always find interesting, and particularly they flash back if they think about they turned on the evening news or plugged into any kind of digital media, and the first thing they saw before the content they were looking for or even the news was an advertisement for any given drug. So this usually catches folks' eyes. We collect these direct costs associated with the drugs that have reported a price increase, and these numbers are broken down into spend on manufacturing, marketing, distribution, and managing safety and effectiveness. So not surprising, and what you notice that for generic manufacturers, almost the entire piece of pie is taken up by manufacturing. That's the nature of their business, and primarily working through wholesalers and not really engaging or necessity to do safety and effectiveness work or research in a significant, or nor for that matter, a heavy amount of marketing needed. But you also see that generic manufacturers reported only 2% of the direct cost associated with distribution, and 12% on the brand side, and likely not to anyone's surprise, 13% for marketing compared to 33% on the brand side. So again, probably not shocking to anyone, but it's something that is visually important to see, and that this is based on real data and not speculation or conjecture. So Durande, next slide, please. And as mentioned, one of the other tasks and pieces of the transparency program is to collect information from manufacturer or from carriers, state licensed carriers rather. So this is showing the breakdown by market segment between individual plans, small group plans, and large group plans in terms of the amount that is spent on a per member per month basis. So this is showing both the amount that is typically spent by the consumer and by the carrier in an average month. The blue bar is showing the percentage of the cost sharing or the copay or the co-insurance that was paid by the consumer, and the orange, of course, being the chunk that was paid by the insurer. And I think what's noteworthy here, even though we're very focused on the cost to consumers, this is really showing, and I think this was a point that Peter or someone else made earlier, that this is really showing the impact of the cost of prescription drugs to insurers as opposed to the consumer, and that even when there are significant costs applied to the consumer, on most cases, that the vast majority of the cost is in fact being covered by the carrier. So you'll also note, and I think this is important, that the cost is significantly higher for individual plans than for small group, and likewise small group than large. So that's really showing something also that we all kind of know intuitively, that but shows visually, that the larger the risk pool you have, the more consumers you have, the more insured lives you have under that, and the more power you have to negotiate for prices. So that's why we see lower prices for large group plans and higher prices for individual plans, which are typically serving a much smaller population. So always an interesting slide. And Durande, next slide, please. So this is really just showing the most costly drugs. This represents drugs which drove most planned spending, and that there are a number of analgesic medications which compete rather with Humira or potential alternatives in this category of autoimmune diseases. I'll also note that Stelara and Skyrizi, which also appear on the list, reflect the very high cost of drugs for autoimmune disorders across the entire market segment. We'll also note that a couple drugs, number 2, Biktarvy, which is an antiviral that's used to pre-exposure and prophylactic and post-exposure prophylaxis for HIV/AIDS, remains on the list as it had previously with $26 million in total claims. Keytruda, which is sort of a blockbuster cancer medication primarily used to treat breast cancer, but also as a number of other indications, is on that list. And of course, as noted, Humira. We'll note that Keytruda as an example, and I think this is something that folks also understand and are aware, that once a manufacturer gets a patent for one individual diagnosis or treatment condition, that often is the first one of many steps to begin to build that patent thicket or wall to prevent biosimilar or generic uptake. So it's all related, if you will. And Geronde, if you would, the next slide, please. Thank you. So kind of consistent with what we just went through, that this is showing drugs with the highest increased planned spending. The last slide showed total spending. So this shows basically the drugs which had the highest increase in spending on a particular drug. Lots of familiar names, as we noted: Keytruda, Skyrizi, and Stelara, also mentioned previously. The other thing worth noting here that I will call out, since we have had some discussions and we'll speak to our transparency public hearing that we had last month around Ozempic and the GLP-1s, as that was noted earlier, is that while these drugs at the time are also used for weight loss, Ozempic, which is primarily used as an anti-diabetic agent, but also having had an effect for weight loss, marketed similarly under Wegovy as an approved weight loss product. And to that point, also worth noting, and part of our work is to have the difficult conversation. So that's what we're just going to do with this one, noting that most insurers are not covering Ozempic off-label as a weight loss drug, and for that matter, many of them are not covering Wegovy as an on-label covered treatment or treatment at this point anyway. And to that point, Medicare is actually specifically barred from doing it. So we got that going for us as well. And we think that this $3 million that we're seeing here is mostly due to the uptake of Ozempic, and noting that there's a lag in data. Would expect that these GLP-1s to go through the roof, if you will. As I told the Senate Healthcare Committee just a couple weeks ago, that these drugs in this kind of frontier class, if you will, put the issues of access, affordability, cost, and equity all on a collision course, specifically the GLP-1. So just saying it out loud because it needs to be said, and we will see where these conversations go from there. But that's the data set, and all publicly available on our website in the report as presented. And then if anyone is ever curious, the website itself's got some pretty slick functionality that if anyone's ever interested in any of the individual medications they take, we encourage you to go and kind of tinker around in there and see what you can find. So I think we should probably pivot to our transparency program recommendations. And Geronde, if you go to the next slide.
Hey, Ralph.
Yes.
Let's have Melissa ask a quick question.
Sure.
And I had just one follow-up for you. Melissa, you're on mute still.
Can you hear me now?
Yes.
Sure, yeah.
All right, Ralph, thanks for we're putting this together. I think one of the challenging parts is I think a lot of times when and Peter, you kind of brought this up, when we talk about prescription drugs, we're often thinking about when a patient or a consumer goes to the pharmacy and they get their prescription and what they have to pay out of pocket. When you look at the drugs that you just were showing on those lists of the largest cost increases, those are being administered and delivered for the most part through a infusion center or through a hospital inpatient or outpatient site of care. They're not at a pharmacy. Generally, it's happening under because they're so new, under the provisor of a physician or a nurse. And one of the challenges when we look at that kind of what portion is being paid by the insurer and what portion is being paid by the consumer is we don't really have view then on, we talked about this, the allowable. We're only looking at the allowable, and we're not really kind of understanding then what a health system is maybe writing off to financial assistance, or the cost of there's a lot of work put in place to try and help patients navigate to coupons and really reduce that financial toxicity related to some of these large cost biologics and new drugs coming in. And this is a super complicated space, whether it's how much it costs to procure, how much 340B savings an organization like mine might be eligible for, how you kind of make sure that it's the best treatment that we all want for our own, our own friends and family. And then kind of, I really appreciate you talking about kind of the direct to consumer. I look at that list and Keytruda is at the top of mine, like how I've seen the spend just skyrocket in our delivery system for treatment. And I think for us as a cost growth committee, it'll be interesting to understand then where are the costs going away from? So when we think about this, what are the therapeutic changes that are happening? So perhaps that patient that had lung cancer before Keytruda, they were having, and this is a finance person talking, so I know I'm way over my skis, but maybe before they were having, lung, surgery, or, Ozempic is another one that perhaps we'll see what are very expensive gastric bypass surgeries decreasing. So how we see shifts, we just can't kind of look at things in a silo related to these therapies and treatments, because in some cases we're seeing maybe less surgeries, less radiology, rad onc treatment, and some of the challenge though is how to put that whole picture together, and then I think also really trying to understand the consumer impact. Because it's so complex around what's coming, at a pharmacy versus what's coming, the really expensive stuff that's coming through the healthcare delivery system directly. So just a couple comments, and appreciate it, and just responding to the complexity of what we're trying to tackle here.
No, absolutely. All great observations. And in fact, really appreciate the financial lens, and just kind of noted there are probably no fewer than 3 or 4, probably a lot more kind of cascading pieces, but just some things that I heard and note there in some of the things you said, and that, cost shifting versus cost avoidance. We don't know. First, to speak to the GLP-1s, and that's not specific, it didn't come specifically to talk about them, but these are new drugs, right? For those of us that are around long enough to remember fen-phen, and other kinds of things, we don't know the long-term, effects of these drugs beyond a lot of clinical speculation that a person will need to be on them for life. So, yeah, there's that. Not specific to the GLP-1s, but to the Keytrudas and other drugs like that you're speaking of. One of the things that the board is going to start looking at through this work with our contractor and potential upper payment limits is, if you will, kind of channel management, if you will. Are drugs like this necessarily, do they always need to come through a medical benefit or a pharmacy benefit? And remember, safety first, not third, for folks that know the construct of white bagging or brown bagging. So these are the difficult kinds of issues. We'll also note, because you mentioned coupons, right? And so I'll actually be speaking about that on the next slide, one of the transparency programs recommendations, because, always being mindful and aware of potential unintended consequences of policy. We want to be able to have good data to make good decisions. And then, just because one of the other pieces that you threw in there was around 340B, and this is, just putting this out there again, it's our job to have these kinds of conversations that, conceivably, are there hospital systems out there that, are buying or purchasing or acquiring a drug for one price, but yet billing an insurer 3, possibly 4 times that price. Those are difficult conversations to have with a hospital setting versus a federally qualified healthcare center. That hospital system isn't doing anything illegal, but is it the right thing to do in the construct of those costs being risk adjusted and aggregated across the entire continuum of lives that everyone is paying for? Difficult questions, difficult, discussions, but appreciate the thought behind them. So
Hey, Ralph,
And-
really,
yeah, Peter,
really,
go ahead.
really quickly, if I can, because you've got this slide up on GLP drugs, and I would probably throw a question on Hemgenix at $3.5 million whack into that as well, which is the impact of these drugs can be really beneficial potentially, and I appreciate the caveat on fen-phen, and we don't know what we don't know yet on GLP-1. But assuming that these drugs have a long-term impact, the way that our system pays for some of these very expensive drugs like Hemgenix, where it's a one-shot deal, but then it saves way down the road, is there any sense at the board of talking about the state building risk pools where all plans would participate and therefore spread that cost in a reasonable way so we don't have to build in the risk component of some of these really high cost medications? Just something that I've been curious about when you talk about how do we provide these drugs at reasonable cost to the system over the course of time and also get the benefit to members.
Sure. So, Pete, I don't think so. And if I'm recalling right from the beginning, I think I saw that Andrew had to drop for a 10 o'clock meeting, or I might see if he could engage. I don't think those are conversations that have happened or that I'm a party to, or ideas that have been baked in the commercial set. I mean, I am familiar in the Medicaid space that there are risk corridors and things of that. So I trust you're talking about that same kind of spirit or context of risk corridors. Certainly something that perhaps there is discussion to have there. So, but I guess the other piece of that is, we talk about some of these things being, Band-Aid kinds of solutions, and what is the end goal? And to that point, does an action like that bring some kind of relief to the system without actually solving the larger problem while the larger problems continue to kind of manifest? So, difficult questions. So, but certainly things that we should be talking about. And anything else? If not, we'll move on. Happy to take other questions or discussion.
Want to just do a quick time check? We have about 10 more minutes before public comment, although at this point we don't have anybody signed up for public comment, so we might be able to take another 10 or 15 minutes.
Okay, why don't we cruise? This is really just a summary that, as noted, we did have these conversations at our transparency hearing in February about both the cost and coverage issues for weight loss and consumer impact on what's been going on in the generic price market. Probably is worth noting, I think there might be some interested folks here. Our drug price transparency public hearing was recorded and does live on the drug price transparency website. We had some fascinating panel presentations on that. One that I would call out specifically there, and I think you could probably parse through it, was a presentation by Dr. David Rind. He's the medical director at ICER, the Institute for Clinical Effectiveness Research. And they did some modeling that I think plans and carriers may have some keen interest in. And that was some slides on what the actual, I think maybe even more, Melissa, to some of your questions, actually, of what some kind of the long-term cost trends on this would be from both a sustainability and a cost avoidance or cost shifting perspective. So not data I have in hand this moment, but something I think folks might have some curiosity in and fairly easy to access through that link. So, and if we can go to the next slide, so I think we should spend a little bit of time on these transparency program recommendations. So trying to move through this fairly quickly. Just finish off by talking about some of these policy recommendations. And because right now patient assistance programs are tethered to price increase reports with our transparency program, we only get a fairly narrow, limited window of exposure as to what those do. So the issue with patient assistance programs is that they're often offered for new, very high cost drugs, some of which haven't even come to market yet in some situations. So, we'll kind of skip some of the personal commentary there, but I think you're connecting some dots in perspective. So concerns that drug manufacturers can use patient assistance programs to disincentivize the consumer from switching to lower cost generic or alternative that Hello similarly has a lower cost share. So flashback to that slide where we had some discussion about the blue and the purple, right? Where the carrier cost was up here. Does it need to be up here? Could it be closer to a smaller number? So recommendation to increase transparency with the patient assistance programs, and then similarly require insurers and PBMs to report on the use of copay accumulators. Been some decisions in federal courts this past couple weeks as it relates to copay accumulators, but by my read, those likely are applicable to ACA marketplace plans. So keeping that perspective. So we did make that recommendation to require some reporting for those. And again, these are going to be longer runway conversations, I think, than any of the committees will have time or interest in during the short 5-week session, but certainly things for them to consider. And Felicia, sorry, Ralph, as you go through these recommendations, are all the changes, are these all changes to, yes, these are recommendations that the transparency program and DCBS as an agency has made to the legislature? And sorry, I heard some external audio. I wasn't sure if that was someone else clicking in. So if we can just hit the next slide, and then I think we're probably just about there and can pause for questions. So again, study the feasibility of state generic manufacturing and extend bulk purchasing, explore a potential uniform drug list for all state programs and PBM services, potential to establish a centralized office of pharmacy purchasing for coordination of all state entities that are purchasing drugs, et cetera. This generic manufacturing one I spoke to earlier, difficult conversations, because what are you doing when you do that if the government were to start procuring or spinning up manufacturers to run cycles of drugs that are in short supply? Do you begin to create a bigger problem where manufacturers exit the marketplace for those drugs? And the intuitive questions is that the role of government? And that's not one I have an answer for today, but the difficult questions and conversations that should be asked. And then lastly, to update our reporting programs for the threshold to align our 60-day notice with our annual price increase, which simply just matches the reporting thresholds for those to reduce administrative burden and increase compliance. So I think that about wraps it up, and certainly happy to take some questions. And if you got to cut me loose for comment, certainly understand that too, but appreciate having an opportunity to speak with you today.
Ralph, thank you very much. It looks like you guys are doing really significant work. This is an area where we have to keep the focus on. What I'd like to do is hear about what the committee thinks about these recommendations. Are there any comments regarding the specific recommendations, or any comments that you might have for Ralph about where there's some focus that you'd like to see?
And sorry, did we answer Felicia's question in the chat previously?
Oh, sorry.
Ralph, about whether or not these changes require legislative action, or these recommendations require legislative action?
Yes, apologies. Yes,
He
Felicia,
did.
they
He
all
did
do.
answer that,
Yes.
yeah.
I'm wondering, Peter, first of all, thank you for the report. Very comprehensive, very clear and very helpful. I don't have any better ideas to add. Do you have any sense of whether the sum of the recommendations will have, what magnitude of change it might have in bending the curve?
I do not. And I say that from both kind of a guarded conservative perspective and at the same time, candidly, a let's swing for the fences perspective. Some of this, I think I noted that the last when we presented our recommendations to you all last year, that we wanted to take kind of a smart, measured approach and not swinging for the fences in our inaugural year. We didn't want to do anything that was going to potentially undermine the credibility or legitimacy of us as a new body. I think this go around this time on the stakeholder engagement and community engagement piece was really important in that it helped us get ourselves out in the community and hear from folks that we otherwise would not have. But I hope that during this next year, and I think this is going to really emerge through our work in the SB 192 implementation, and that is to really probably start to make some more bold, more progressive kinds of policy recommendations. To that point, we are an advisory committee, and that is, while professional staff, we support a volunteer board, just as you all are volunteers. So always cognizant of that. But at the same time, believe that we need to go big or go home in these conversations at some point. To that point, we'll see what happens.
Thank you.
Sure.
Lisa, did I see a hand pop up? No. Anybody else want to make any comments? I have one quick comment, and it goes back to some of my remarks preceding this discussion. Ultimately, we're going to have the ability to impact the overall price. What's the committee's view of some of the work that Florida's doing with Canada, and/or what's the committee's view of getting to the heart of being able to negotiate drug prices for the benefit of Oregonians? I think we froze. There you go. Now you're back.
Peter, if I could just jump in, as I often do. I was really struck by the difference of both total cost and member cost between individual plans and group plans, and that large group plans, and that shows, gives you a clue of the power of negotiating, and maybe we could make it even more powerful, and that it is so heavily burdened, particularly on the individual plans. I think we need to find a way to get the collective bargaining power of Oregon, however that works, into play here, because that's just, it's so dramatic and it is so impactful.
Absolutely, and I would agree with that comment. Charlie?
Well, I mean, I think for me, from this whole presentation, what I'm most interested in and think is the most promising avenue to actually get at prices is the upper payment limit recommendation and report that's coming out in September. For me, I appreciate all the transparency suggestions that are in there, and I think there are a lot of things around PBMs and copay accumulators and patient assistance programs that are important for us to know more about. But at the end of the day, it does seem like the prices, the beginning, like the top of the funnel, or in a lot of ways, the most important thing. And I'm hopeful that we'll be able to have a strong recommendation coming out of that. And then, the legislature hopefully will be responsive to that. And Oregon can be in the first couple states to actually have upper payment limits implemented and learn from what other states are doing and, actually get at prices.
Lisa?
Yeah, I was just wondering, Ralph, how much are top 25 drugs, to Melissa's point, around most of them are hospital administered drugs. How much of them overlap with California, Washington, and Alaska?
Ooh, Felicia, you are asking me a question that I don't have data readily available for, but
Sorry.
would
Okay.
no worries, would happily circle back with Sarah and get have my data folks pull that and get something back out to y'all if helpful. I mean, speculation, which is always dangerous, right? Is that there's probably quite a bit of alignment there.
Yeah. So, I mean, I think that to me is a place where I think when we talk about bulk, oftentimes when we talk about bulk purchasing, we talk about it as if the state will then bulk purchase. But the reality is if we could get our health systems that overlap in those states to bulk purchase for their full cost of those states and figure out how we use the state's power to allow them to drive and change a market. I think to me that actually could, when you look at that drug cost, that could actually change. And if you just started with those, let's say top 5.
Yeah, no, agreed, and certainly a worthwhile conversation. The only thing to flag, and I think this group will get this, is that where that, and a little bit maybe to Charlie's point, in an upper payment limit construct that yet to be baked, if you will, is, this is not about squeezing the pharmacy at the end and putting the pharmacy out of business in rural Oregon or in downtown Portland or anywhere else in the state for that matter. I think there can sometimes be a tendency to let downward market pressures do their thing. And if in this case, those market pressures just wind up shuttering, community retail pharmacies, then there's no access, and that's a whole different problem that we have. So I just wanted to say that part out loud, that we need to be mindful.
Yeah, I'm sorry. I specifically was talking about the hospital administered drugs.
Sorry, apologies.
So I think that almost all of our health systems overlap in those states and have some sort of market share across those states, are large ones anyway. And the hospital administered drugs are a place where there's quite, as Melissa pointed out, when you look at that top 25 list, a huge number of those are hospital administered drugs.
Right. We also, but again, and this is some of the, and Sarah, I will defer to you on time because you all know I could keep talking about this stuff as long as you would want me to. But to that point, again, some of the difficult conversations around transparency of what things might actually cost, say, a 340B hospital. And if in fact that entity is billing for several times or more what that drug, actually cost them versus, should they be charging the same amount as a non-340B hospital because they got the drug, for half the price or less? I don't know the answers to those, and I'm not going to try to answer them today. But what I can tell you is that for any kind of comprehensive, upper payment limit methodology, there will likely need to be some kind of transparency element on the hospital side. And I think that there are entities like the National Academy of State Health Policy that I'm closely affiliated with and involved with are starting to have some of those conversations about what some of those reporting pieces might look like, because you can't just have the conversation the hospital's paying too much or the hospital is billing too much if you don't know what the hospital actually paid for it. And those are difficult conversations, both in the legal aspects of trade secret and confidential business practices, as well as kind of the public facing pieces of what's right. So again,
And
that's our work to have these difficult conversations. So that's what we do.
And I think that actually feels like a really great segue. I know that we're close on time, and I'm going to sort of co-op from Felisa and Peter for a second, because we are holding the February advisory committee meeting open as a placeholder, because we assumed we needed to have and wanted to have more conversations about pharmacy costs, pharmacy strategies, potential recommendations that this committee could be developing or supplementing to add on to the work of the Prescription Drug Affordability Board and Price Transparency Programs. So in our last few minutes, I would love to hear from committee members how we should shape that February agenda. We have another 90 minutes dedicated to pharmacy. We also have a potential placeholder time for an educational webinar where if we need to provide some more background information on any of this or go deeper into any of the data, we could do that in between the meetings. But how can we best set up for that conversation in February? Where would you like to go next?
Sarah, I think it would be helpful if we had a conversation in February that was about the recommendations that Ralph laid forward in more detail about what are some of the things that we think we should, are there things that we could jointly support with this group? And then also, I feel like the other piece of this conversation in February, I think as we were talking, like, what a little bit about what our takeaways were and was there anything missing from those recommendations. That's how I'd like to spend our 90 minutes in February.
Jessica?
Yeah, it would be great to talk about how this intersects with our work. So the trends we're seeing, especially as we need to report out on drugs administered in a facility. I think how it impacts the cost growth target and what we need to consider as an advisory board here would be a great conversation.
Any other comments? I think Felicia's right on. I think if we could lay out the recommendations that Ralph has provided in this discussion, we can focus in on those and then also bring lists of those things that you think are missing. And we can provide some input to the board through Ralph. Ralph, I want to thank you for a really well done presentation. Thank you for the work that you guys are doing. There's lots more ahead.
Thank you so much. We appreciate being here today and happy to come back. Thank you.
All right, Sarah, are we wrapping up?
I think so. Nobody has said anything about public comment, so just maybe final call. Was there anyone joining the meeting today that wanted to provide public comment?
Hearing none, we'll close that off. As Sarah pointed out, we're going to do a deeper dive into pharmacy for the next meeting. And then we'll continue to build the agenda throughout the year. Really appreciate everybody's participation. I don't know about you, but I like this shorter format. I don't sit well for 3 hours, so this is great. All right. Anything else, Sarah, before we close off? All right, we're adjourned. Thank you very much, all.
Thank you.
Thank you.